Welcome back to the deep dive. Usually, we are taking a wide lens to the world, history, tech, whatever grabs our attention. But today is different. We're narrowing the aperture.
We certainly are.
We are turning this studio into a bunker, a high-stakes, coffee-fueled study bunker.
That's a good way to put it.
Yeah.
We're putting aside the usual casual curiosity for, well, professional necessity.
The scenario for you listening is this. I am a postgraduate student. I'm prepping for my MD anesthesiology exams at Gujarat University. And you, my friend, you're the senior faculty member. You've seen decades of the exams, you know all the examiners, and you are here to give me that final, terrifying Viva review.
No pressure, then.
Oh, tons of pressure. The topic is massive. Regional anesthesia in ophthalmic surgery with special emphasis on cataract surgery. I've got my Miller, my Morgan, my casebooks all spread out here. My goal is to get this information out of the dense text and into a format I can actually speak to an examiner about.
And you have to.
Yeah.
This is a staple topic. If you are sitting for your MD, you absolutely cannot afford to be weak on the eye.
Why is that?
It covers everything. It's anatomy, it's pharmacology, it's physiology, especially intraocular pressure, and it's high-stress crisis management. It is, the perfect storm for an examiner to test whether you are actually safe to practice.
Okay, so let's treat this like a real review session. Part A, introduction and exam framing. Why does this topic keep coming up? I mean, cataract surgery feels so routine, doesn't it?
It is routine,
Yeah.
and that's exactly why it matters. Cataract surgery is the most frequently performed surgery in the world. The sheer volume is just staggering.
Right.
But for the exam, you need to be able to articulate the massive shift in how we handle these patients. We've moved away from general anesthesia or GA for the vast majority of cases. The sources all point to something like 86% or even more now being done under local or regional.
So if I get a question on anesthesia for cataract and I, start talking about intubation and GA, I've already failed.
You've certainly dug yourself a hole, a big one. Unless there is a very specific indication, like a pediatric patient, a mentally challenged patient who just can't cooperate, or maybe a ruptured globe regional is the gold standard, you need to explain why.
And the why revolves around the patient profile, right? The person on the table.
Exactly. Look at who gets cataracts. It's the elderly. Patients over 65, often over 75 or 80. They don't just come with cloudy lenses. They come with a medical history file that is, 3 inches thick.
Sure. Hypertension, diabetes, COPD.
Ischemic heart disease. The works. Putting these patients under GA exposes them to all sorts of risks. Hemodynamic instability, aspiration, prolonged recovery.
Plus that brain fog people talk about.
All right, postoperative cognitive dysfunction. In an elderly patient, GA can leave them confused for days. Regional just avoids that. It helps with daycare surgery, which is cost-effective, and it gets them back to their home environment faster, which reduces infection risks.
Okay.
But there is one crucial physiological reason you absolutely must mention to the examiner.
And that is?
PONV. Postoperative nausea and vomiting.
Why is that so critical here? It's bad everywhere, but why specifically for eyes?
Because vomiting is basically a Valsalva maneuver. It causes a massive spike in venous pressure, which translates instantly to a massive spike in intraocular pressure, or IOP. If a patient retches after eye surgery, they can literally blow out the incision. It can cause an iris prolapse or, worst case, an expulsive hemorrhage. Regional anesthesia has a much, much lower risk of PONV compared to GA, so it's a huge safety issue for the eye itself.
Okay, that's a fantastic framing. Now, what kind of questions am I actually walking into? Is it a long answer? Is it a Viva?
It could be both. In a theory paper, you're looking at a classic 10 or 20 marker, something like classify ophthalmic blocks and describe the technique and complications of Peribulbar block. For that, you need a very structured long answer.
Right.
In a Viva, though, it's different. They'll throw you a curveball. You're monitoring a block. The patient suddenly stops breathing. What happened? Or the surgeon pulls on a muscle and the heart rate plummets to 30.
The Oculocardiac reflex.
We'll get there. But you see the difference. You need to be ready to pivot from those long, descriptive answers to rapid-fire troubleshooting.
Okay, let's move to part B then, basic concepts. Before we even think about picking up a needle, what are the ideal conditions? What does the surgeon want? What is the perfect eye?
This is a great place to start your written answer. We call these the 5 A's of ophthalmic anesthesia. If you are writing an answer, list these as headers. You'll get marks just for the structure alone.
Hit me. What are they?
First is analgesia. The eye is incredibly sensitive. We need a complete, profound sensory block of the conjunctiva, the cornea, and especially the uveal tract.
So no pain at all?
None. The second is akinesia. The eye must be absolutely immobile. Remember, this is microsurgery. The surgeon is working under a high-powered microscope. If the eye twitches even 1 millimeter, it looks like an earthquake in their visual field. A moving eye can lead to a posterior capsule rupture. It's a disaster.
Okay, so numb and still. What's third?
Third is akinetic eyelids. And this is distinct from the globe itself. We need to paralyze the orbicularis oculi muscle.
The muscle that lets you squeeze your eye shut.
Precisely. If the patient retains the ability to squeeze or squint, it exerts external pressure on the globe. We call this the squeezing effect. It could literally push the vitreous humor out of the eye.
Wow, that's a vivid image.
Fourth is IOP control. We need a soft eye. High pressure makes the surgery technically difficult and very dangerous.
And the last one?
And fifth is cooperation. Your patient is awake, they're lying under a drape, they can't see anything, they need to be able to lie flat, breathe calmly, and follow basic commands. If they can't, say due to dementia or a severe tremor, then regional might actually be contraindicated.
Okay, let's talk anatomy. This is the part that, I'll be honest, scares me. The orbit is such a complex space. How do I visualize this for the exam?
Keep it simple but accurate. Think of the orbit as a bony pyramid. The base is your face. It's anterior. The apex points backward and medially, deep into the skull. The depth is about, say, 45 to 50 millimeters, but the eyeball itself is only sitting in the front part of that space.
Right.
The most critical concept you must be able to explain is the muscle cone.
I see this term everywhere. Intraconal versus extraconal. This is what they're talking about.
This is it. Visualize the four rectus muscles. Superior, inferior, medial, and lateral. They all originate from this little fibrous ring at the very apex of the orbit called the annulus of Zinn.
Annulus of Zinn. Okay.
As they come forward to attach to the eyeball, they form a cone shape behind the globe.
And this cone is the target, or the landmark.
It's the boundary line. It's what separates the two main needle techniques.
Okay, so what's inside the cone?
The really important stuff. The optic nerve runs right down the center of this cone. The ciliary ganglion, which is a key target for our nerve blocks, sits inside this cone, just lateral to the optic nerve.
A retrobulbar block.
Puts the needle inside the cone. It's intraconal.
And a peribulbar block.
Puts the needle outside the cone, extraconal. It relies on the drug soaking through the muscle sheath to get to the nerves inside.
That clears up so much. Now, there's a specific number mentioned in all the textbooks regarding axial length. This feels like a classic Viva trap.
It is the single biggest trap in this entire topic.
Yeah.
The normal axial length of the eye, from front to back, is about 25 millimeters.
Okay.
However, consider the myopic patient, the very nearsighted patient. Their eye is elongated. It might be 26, 28, even 30 millimeters long.
So the eye is just bigger.
It's longer. And because it has stretched over time, the sclera, the white wall of the eye, can be paper thin in some spots. You call this a staphyloma.
Right.
If you stick a needle blindly into the orbit of a high myopia, the risk of globe perforation is exponentially higher. The eye is physically taking up space where you expect your needle to be going.
So if the examiner says the patient has -8 diopters of myopia, or they wear very thick glasses, what's my response?
Your response is, my first concern is the increased risk of globe perforation due to a potentially long axial length in staphyloma. I would check the biometry report for the axial length. I would proceed with extreme caution, and I would likely avoid a sharp needle retrobulbar technique entirely to prevent perforation.
That's the safety answer.
That is the answer that passes you.
Okay, let's classify these blocks. Part C. How do I organize this for a long answer? I can't just list them randomly.
No, absolutely not. Use a classification tree. It shows the examiner you think in a structured way.
So how would you group them?
I'd say group 1, topical and anterior techniques. These act on the surface. We're talking about topical drops, subconjunctival injections, and intracameral injections by the surgeon.
Okay, surface level.
Group 2, posterior or orbital techniques. These are the main blocks, the workhorses. This is your subtenons, your peribulbar, and your retrobulbar.
Got it.
And then group 3, facial nerve blocks. These are specifically for the eyelids, for that orbicularis oculi muscle we talked about.
And I've seen examiners ask for a classification based on needle versus cannula.
Yes, that's another smart way to classify. It shows you're thinking about safety. Subtenons uses a blunt cannula. Peribulbar and retrobulbar use sharp needles. That distinction is absolutely vital when you start talking about the safety profile of each block.
Okay, let's dive into the specifics then. Part D blocks used in cataract surgery. Let's start with topical. It seems to be taking over everything.
It really is the standard for modern phacoemulsification.
And why is that?
Because phaco uses tiny incisions. We're talking 2 to 3 millimeters. They're self-sealing. The surgeon doesn't even need sutures. And because the eye remains a closed, pressurized system, they don't strictly need the eye to be paralyzed, the akinesia. They just need it to be numb.
So what's the regimen? Is it really just eye drops?
It's a bit more involved than that. You typically start with drops like proparacaine 0.5% or tetracaine 0.5%. You instill them every 5 minutes for about 4 or 5 doses before the surgery begins.
Right.
But the drops don't really numb the inside of the eye fully, especially the iris. So the surgeon performs what's called intracameral anesthesia. They'll inject preservative-free lidocaine, 1%, directly into the anterior chamber right at the start of the case.
You're emphasizing preservative-free. Why is that so important?
Because preservatives, like methylparaben, are incredibly toxic to the corneal endothelium. If you damage that layer of cells, the cornea swells up and clouds over permanently. You can blind the patient. So preservative-free is a mandatory keyword for your exam.
Okay, let's do a quick pros and cons table for topical for the exam.
Easy. Pros: no needles. That means 0 risk of retrobulbar hemorrhage, 0 risk of perforating the globe, and because the optic nerve isn't blocked, the patient has vision immediately after the surgery.
And the downsides.
Cons: the eye moves. There is no akinesia. If the patient is very anxious or has a tremor, it makes the surgeon's job extremely difficult. Also, the iris is not fully anesthetized by the drops. If the surgeon accidentally touches the iris, it hurts, and the patient will jump.
So you need a very cooperative patient.
And a very skilled, fast surgeon.
Okay, next up, the Sub-Tenon's block. The sources are calling this the exam favorite.
Or pinpoint anesthesia. This block is really the darling of safety-conscious anesthetists. It kind of bridges the gap. It gives you the safety of having no sharp needle, but the effectiveness of a much deeper block.
Walk me through the technique, step by step, like I'm doing it.
Okay, visualize it. First, you apply topical drops just to numb the surface so the patient doesn't feel the next steps.
Mm-hmm.
You insert a speculum to keep the eyelids open. Then you have the patient look up and out. This nicely exposes the infranasal quadrant of the eye.
Up and out, got it.
The anesthetist then uses little forceps to gently lift the conjunctiva and the Tenon's capsule. That's the membrane around the eye. About 5 to 10 millimeters from the limbus, the edge of the cornea.
Okay.
You make a tiny snip with blunt-tipped scissors. Then you insert a blunt cannula. You should name it Stevens or a Greenbaum cannula. It's curved specifically to follow the shape of the globe.
And the blunt cannula is the key safety feature here.
It is the entire point of the block. Because it's blunt, you can feel the resistance of the sclera, but you're very unlikely to pierce it. You slide it back past the equator of the eye and then inject 3 to 5 milliliters of local anesthetic.
And how does that work? Where does the drug go?
The fluid spreads under Tenon's capsule, and it tracks all the way back into the retrobulbar space. You get excellent analgesia and usually very good akinesia.
Is this the one you'd use for patients on blood thinners?
It is the technique of choice, absolutely.
Yes.
If a patient is on warfarin or clopidogrel and you can't stop it for the surgery, you use the Sub-Tenons. The risk of a significant orbital hemorrhage is minimal because you aren't passing a sharp needle blindly through the orbital fat.
Okay, now for the big one, the Peribulbar block. The outline says this is absolutely essential.
This is the most common needle block you'll be asked about. The core concept here is that it is extraconal. We want to flood the orbit with a large volume of anesthetic outside the muscle cone and then rely on pressure and diffusion to get it to soak in.
So what's the technique? Where do you put the needle?
You use a short needle, usually 25 millimeters, 25 gauge. The classic entry point is inferotemporal. Imagine the lower eyelid. You go to the junction of the lateral 1/3 and the medial 2/3. You go just above the bony orbital rim.
Okay.
And here's a key point. You advance the needle parallel to the floor of the orbit. You do not aim up towards the eye. You're aiming straight back.
And you mentioned a high volume.
A very high volume compared to other blocks.
Yeah.
6 to 10 milliliters. We need that volume to generate enough pressure to push the drug through the fascial layers and into the muscle cone.
Pros and cons.
Pros. It's significantly safer than a retrobulbar block because you are not intentionally aiming for the apex where the optic nerve and all the major vessels live.
It's slower. It can take 10 to 20 minutes to fully set in. It also has a higher failure rate. Sometimes you need to do a top-up injection. And because of that high volume, you often get chemosis, which is swelling of the conjunctiva, and frequently a black eye or ecchymosis.
And that brings us to the classic, the retrobulbar block.
The intraconal block. This is Atkinson's classic technique, the one you see in all the old textbooks.
Right.
You enter at more or less the same spot in ferrotemporal, but once the needle passes the equator of the eye, you change direction. You angle it up and in towards the apex of the orbit.
Towards the annulus of Zinn.
Exactly. You are aiming for the ciliary ganglion inside the cone. Anesthetists who do it describe feeling a distinct pop as the needle passes through the intermuscular septum.
So why is it less preferred today if it's so direct?
It's extremely effective, don't get me wrong. You use a low volume, 3 or 4 milliliters, and you get almost instant dense akinesia. But the risks are just so much higher. You are working blindly with a sharp needle right next to the optic nerve and the ophthalmic artery.
So the big 3 complications we'll talk about later.
Yes. The risk of retrobulbar hemorrhage, optic nerve injury, and especially brainstem anesthesia is significantly higher with this technique. In the exam, you should only defend this technique if you're specifically asked, or for a very specific case. Otherwise, you preach safety with peribulbar or subtenons.
Okay, quick tangent, but an important one. Facial nerve blocks.
Right. Remember, the orbital block stops the eye from moving. The facial block stops the lids from closing. You're targeting the orbicularis oculi.
And what are the types I need to know?
You just need to know them conceptually. There's the Van Lint block, which is basically an infiltration of the terminal branches at the orbital rim. There's the O'Brien block, which targets the nerve trunk at the mandibular condyle. And then there's the Nadbath block.
The Nadbath. This sounds like another trap.
It's a massive one. The Nadbath block targets the facial nerve as it exits the stylomastoid foramen, which is just behind the ear.
Oh, okay.
But that foramen is very close to other critical nerves, specifically the vagus, the glossopharyngeal, and the spinal accessory nerves. If your local anesthetic spreads and blocks the vagus nerve, you can cause vocal cord paralysis.
Which would cause?
The patient develops stridor, laryngospasm, or even complete respiratory distress on the table. It's a huge deal. If you mention the Nadbath block in your exam, you must mention this specific, dangerous complication.
Okay, let's move to party drugs and technique. What are we actually putting in the syringe for these blocks?
It's usually a cocktail. You're combining agents to get the best properties of each.
So what's in the mix?
You almost always start with lidocaine 2%. It gives you a very rapid onset within a few minutes. Then you mix that with bupivacaine 0.5% or 0.75%. Bupivacaine is much slower to work, but it provides duration. It keeps the eye comfortable for hours after the surgery is over.
And what about that spreading factor I've read about?
Hyaluronidase. This is an enzyme that hydrolyzes hyaluronic acid in the connective tissue. Think of it as a substance that temporarily dissolves the cement between cells.
Which allows the local anesthetic to spread more easily.
Exactly. For a peribulbar block where we are totally reliant on diffusion, hyaluronidase is basically mandatory. It improves the quality and the density of the block, and it speeds up the onset time significantly.
What about adding epinephrine? I see that in other regional blocks.
You can. It causes vasoconstriction, which reduces bleeding in the tissues and prolongs the block by keeping the local anesthetic from being washed away. But UT, and this is a big, but remember your patient.
Elderly, cardiac disease, hypertension.
Right. If that epinephrine gets absorbed systemically, it can cause tachycardia or a hypertensive crisis. You have to use it with extreme caution, if at all, in this patient population.
Okay, let's talk about sedation. You called this the Goldilocks challenge earlier.
It really is. It's an incredibly delicate balance.
What's the risk of getting it wrong?
If you give too little sedation, the patient is anxious, their blood pressure is high, and they're more likely to move. If you give too much, they fall asleep. And what happens when you sleep?
You snore.
And snoring moves ahead. Or worse, their airway obstructs. And remember, the drapes are covering their nose and mouth. You do not have easy access to their airway if something goes wrong.
There's also the risk of confusion, right?
Yes, paradoxical disinhibition. Benzodiazepines especially can cause this in the elderly. They might seem sedated, then suddenly wake up agitated and thrashing in the middle of the surgery. A complete nightmare.
So what's the strategy then? What's the safe way to do it?
Honestly, the best tool is verbal anesthesia. Holding their hand, talking to them calmly. If you do need drugs, use tiny titrated boluses. Midazolam 0.5 to 1 milligram, fentanyl 10 to 20 micrograms. Watch and wait.
Any specific drug that's good here?
Dexmedetomidine is an excellent choice and a great keyword to drop in the exam. It provides what we call cooperative sedation without causing significant respiratory depression. The patient is calm but can still be roused to follow commands. It's almost perfect for this scenario.
All right, Part F, complications. This is where it gets serious. The outline says absolutely essential. Let's break down the big ones.
You must know the big three in detail. These are the sight and life-threatening ones. Number 1, retrobulbar hemorrhage. Number 2, globe perforation. Number 3, brainstem anesthesia.
Okay, talk to me about retrobulbar hemorrhage. What happens?
You've hit an artery behind the eye, usually the ophthalmic artery or one of its branches. Blood starts to rapidly fill the closed space of the muscle cone.
What are the signs? What do I see?
You'll see the eye start bulging forward. We call that proptosis. The eyelids will get incredibly tight. You'll see a subconjunctival hemorrhage, a big red patch on the white of the eye. And if you gently palpate the eye through the lid, it will feel rock hard.
And the danger is the pressure.
It's orbital compartment syndrome. The pressure builds up so high that it cuts off the blood supply to the retina through the central retinal artery. Blindness can happen in minutes.
And the management is surgical.
It's an immediate emergency procedure called a lateral canthotomy. You have to cut the tendon at the outer corner of the eye to release the pressure and save the patient's sight. And obviously, you cancel the cataract surgery.
Wow. Okay, number 2, globe perforation.
This is exactly what it sounds like. You stick the needle into the back of the eyeball.
How would you know?
The patient might feel a sharp sudden pain during the injection. The eye, instead of getting firm from the injection, will suddenly become soft or hypotonic. If the surgeon looks in, the normal red reflex will be lost because there's now blood inside the eye.
And the biggest risk factor here is?
High myopia, that long axial length we talked about. Always check it. Management is to stop everything and get an immediate referral to a retina specialist.
Okay. Brainstem anesthesia. This one sounds terrifying.
It is the silent killer of ophthalmic blocks. Remember we said the optic nerve is covered in a sheath that's continuous with the meninges of the brain?
Right. It contains CSF.
If you accidentally inject your local anesthetic into that dural sheath, the drug will track straight back along the optic nerve to the midbrain and the pons.
Oh, that's the presentation.
It happens very fast. Within a minute or two, the patient will stop talking. They will become apneic. They will simply stop breathing. They lose consciousness. You might see the pupil on the other eye dilate.
And manage.
It is purely supportive. ABC, airway, breathing, circulation. You must intubate and ventilate the patient immediately. The block will wear off in a few hours. If you support them through it, they will survive with no deficit. If you miss the apnea because you're chatting with the surgeon, they die. It's that simple.
Okay, and finally, in the complications list, the Oculocardiac reflex, OCR.
This is a reflex arc you have to be able to recite in your sleep.
Go ahead.
The afferent limb, the sensory part, is the trigeminal nerve, specifically V1. The trigger is traction on the extraocular muscles, especially the medial rectus, or simply pressure on the globe itself.
And the efferent.
The motor response.
The efferent limb is the vagus nerve, cranial nerve 10.
And the result is?
Severe bradycardia. The heart rate can drop into the 30s. You can see nodal rhythms or even a full-on asystole.
So VIVA scenario. The monitor starts beeping. The heart rate is 30. What is the absolute first thing you say?
Stop the stimulus.
Yeah.
You must tell the surgeon to let go of the muscle immediately. That is the #1 answer. 9 times out of 10, the heart rate will recover instantly. And if it doesn't?
Then you move on. Ensure the patient is getting 100% oxygen. If the bradycardia persists, then you give IV atropine or glycopyrrolate. But stopping the traction is always step 1. Giving drugs first is a failing answer.
Got it. Part G. Special considerations, high-risk patients.
Right. What if the patient has tremors, like from Parkinson's disease?
The shaking head seems like a bad thing for microsurgery.
It's a relative contraindication for regional. You simply cannot operate on a moving target. These patients will likely need a general anesthetic to ensure the eye is perfectly still.
What about patients with severe COPD or CHF?
Orthopnea. They can't lie flat for 30 minutes without getting short of breath. You can try propping them up with pillows, but that makes the surgical angle difficult for the surgeon. Sometimes the best plan is just a very fast surgeon, or, again, GA.
And the big one? Anticoagulants.
If the patient is on warfarin, clopidogrel, any of the new agents, you switch your technique. You use Sub-Tenons or topical. You avoid sharp needle blocks to minimize the risk of a catastrophic orbital hemorrhage.
Let's talk about daycare surgery. How do we decide who is safe to go home?
You use a scoring system, like the PAT criteria. You need stable vitals. The patient needs to be alert and oriented. Minimal or no nausea. No active surgical bleeding.
And the most important thing?
A responsible escort. They will have an eye patch on. They have lost their monocular vision and depth perception. They cannot drive a car or safely navigate public transport home alone. This is a critical discharge point.
Okay. Part H, exam integration. Let's hammer this home with some direct comparisons. First, topical versus peribulbar.
Okay. Topical, it's fast, it's safe from needle risks, the bad. The patient can be anxious, and the eye is still moving.
You get total akinesia, a completely still and painless eye, the bad. It involves needles, so there's a risk of hemorrhage, and it's much slower to take effect.
Okay. Retrobulbar versus peribulbar.
This is a classic. Retrobulbar, you use a low volume of drug. It's very fast, very reliable, dense block.
Yeah.
The bad. High risk of optic nerve injury and brainstem anesthesia because you're in the cone.
You use a high volume, it's much safer because you're extraconal. The bad, you get chemosis, that's swelling, it's slower to work, and it has a higher failure rate.
What are some other common Viva traps I should watch out for?
Okay, a few more. 1, axial length. We've covered it, but it's worth repeating. Failing to consider the risk of perforation in a high myope is a major red flag.
2,
The NAD-BATH block. Forgetting to mention the risk of vocal cord paralysis shows a gap in your safety knowledge.
3,
OCR. Giving atropine before asking the surgeon to stop the traction. Wrong order of operations.
and 4.
Basic anatomy. Not being able to state that the ciliary ganglion is the primary target for the retrobulbar block. It shows you haven't understood the fundamentals.
Finally, diagrams. What should I be able to draw from memory?
3 things. 1, the orbital pyramid. A simple cross-section showing the annulus of Zinn and the muscle cone. It's easy and it's high yield.
Okay.
2, needle trajectories. Draw the globe in the cone and show the peribulbar needle staying outside the cone and the retrobulbar needle angling up and inside it.
And the third one?
Sensory zones of the face. A simple drawing of a face, mapping out the areas supplied by V1, V2, and V3, the 3 branches of the trigeminal nerve. It demonstrates you understand the broader anatomy.
Okay, let's wrap this entire session up. Give me the summary, the final elevator pitch I can use for my exam conclusion.
Here's your recap. This is your concluding paragraph. Ophthalmic anesthesia is fundamentally about balancing the need for optimal surgical conditions like akinesia and a soft eye with paramount patient safety. While topical anesthesia is growing for routine phacoemulsification, regional blocks, particularly the safer Peribulbar and Sub-Tenon's techniques, remain the gold standard for more complex cases or for trainee surgeons. My priority as the anesthetist is always safety. This involves a thorough preoperative assessment, specifically checking axial length to prevent perforation, choosing a non-needle technique in anticoagulated patients, and maintaining constant vigilance for the recognition and immediate management of life-threatening complications like brainstem anesthesia and the oculocardiac reflex.
That is an masterclass.
Yeah.
I honestly feel like I can visualize that muscle cone now.
Good, because you can be sure the examiner definitely can.
Thank you so much for this. And to you, the listener, good luck with the Gujarat University exams. Go practice those diagrams.
Good luck. Stay safe.